السلام عليكم ورحمة الله وبركاته، وأسعد الله جميع أوقاتكم بكل خير. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وبعد. We will start today Exanthematous diseases, including the viral exanthems, and we will start by measles. The objectives for this lecture: by the end of this lecture, every student will know the infections with rash, the types of rash and description, and he will know the measles. The measles regarding the epidemiology, pathogenesis, clinical picture, diagnosis, complications, managements, and prevention. Infectious diseases with rash, we have maculopapular rash and papulovesicular rash. Regarding the viral diseases with maculopapular rash, including measles, rubella, rosolia infantium, erythema infectiosa, infectious mononucleosis, Coxsackie, and echoviruses. Bacterial diseases causing maculopapular rash, including scarlet fever, meningococcemia, and typhoid fever. Fungal infections like tinea, allergic conditions causing maculopapular rash like insect bite, and again parasitic infections like scabies, and collagen diseases like systemic lupus erythematosus and rheumatoid arthritis. While the causes of papulovesicular rash, the viral causes including smallpox, which is eradicated, the chickenpox, herpes simplex, Coxsackie virus. While the bacterial infections causing papulovesicular rash, including impetigo, fungal infections like tinea, allergic causes like insect bite, and so on. Now, before starting exanthematous diseases, we have to know the type of rash. So this will help the student to describe the rash, and the description of the rash will help in the diagnosis. Again, if you make any referral or consultation and you are not aware with the type of rash, this will lead to wrong diagnosis. That's why we have to know the primary skin lesions. The definition of the macule is a change in the skin color, but it is not felt, while the papule is palpable raised skin lesion below 1 centimeter in diameter. If it is more than 1 centimeter in diameter, we call it nodule. The vesicle is raised a fluid-filled lesion. This vesicle should be below less than 0.5 centimeter. But if it is more than 0.5 centimeter, we will call it bulla. The fourth lesion is pustule, which is vesicle containing pus, while the plaque is aggregation of any primary lesion. This picture shows different macules change in the color. Red here, it is red change in the color of the skin. The papules raised skin lesion. Vesicles, it is papule containing fluid. The bulla is big vesicle, while the pustule is a vesicle containing pus. This is a plaque, which is aggregation of primary lesions, and this shows plaques in the arm. Now we will start by measles. To start by measles, really for a long time we didn't see measles cases in Gaza, but there was an outbreak. This outbreak was last year in year 2019, and these informations I got it from the WHO. This is from the 1st January through 19th of December 2019, a total of 124 laboratory confirmed cases of measles. So this is the laboratory confirmed cases, and you heard about these cases, of course. And we have some students who got measles and they were isolated at home. And again, we have some of the employee doctors in the hospitals. They had measles and they were isolated, and one of them was admitted even to the ICU. 2 deaths were reported in Gaza Strip. So the case fatality rate is 1.6%. Of the confirmed cases, 49 cases, that is 40% of the cases, were hospitalized. 12 were among healthcare workers, as we mentioned before. And 75% of the cases, about 60%, they were male. 57 cases, that is 46%, were unvaccinated. This is the cause of getting measles because they did not get the vaccine, of which 28 cases were among infants between 6 months to 1 year old, because you know that MMR vaccine, including measles, is given at the age of 12 months. So we got some cases below the age of 12 months. And 29 of cases, they were among a group higher than 30 years. And this is important because probably the vaccination immunity, maybe it was tapered away, and they didn't get booster doses. Between 2009 and 2018, the median administrative immunization coverage for the second dose of measles containing vaccine was 97%. This means that the coverage of MMR was 97%. In Gaza Strip, MMR vaccine is given to the children 12 to 18 months of age. Of course, 1 dose is given at the age of 12 months, and a booster dose is given as 18 months, as we discussed in the lecture of immunization. MMR induced in 1988 as a single dose in Gaza and in Palestine, and the second dose introduced at 18 months of age in 2009. This means that all those delivered before 2009, they got only 1 dose of MMR. That's why maybe this is one of the causes of the measles outbreak. Since 1968, there were no measles cases in Gaza. But there is 1 case was confirmed in year 2000. Otherwise, we didn't see cases of measles at all here in Gaza. This, if you need more information about the measles outbreak, you will go to the WHO website link here, found here. So you open this link and you can find all the informations about Gaza outbreak in year 2019, which is the last year. We have some facts about epidemiology of measles. In 2016, there were 89,780 measles deaths globally. This is marking the first year measles deaths have fallen, and this one now is fallen. It's below 100,000 per year. Measles vaccination resulted in a 84% drop in measles deaths between 2000 to 2016 worldwide. So there is a drop of the number of measles cases. You know, Some of the cases will appear in the areas of wars, and some people, they refuse vaccinations. You will find some countries with low immunization coverage. That's why they have still measles cases. And during year 2000 to 2016, measles vaccination prevented an estimated of 20.4 million deaths, making measles vaccine one of the best buys in public health. The etiology of measles is RNA virus, the measles virus, or rubiola. They call it rubiola virus. Don't think it is rubella. Rubella is German measles. So this is rubiola virus. It is an RNA virus in the family of Paramyxoviridae. Regarding the epidemiology of measles, 90% of children have the infection before the age of 15 years. So it is a childhood disease. The incidence declined dramatically following the introduction of the measles vaccine. The introduction of measles vaccine was in the year 1963. From that time, a gradual reduction of measles cases worldwide was there. It is most common in the winter and spring. Measles, as you know, measles, I remember when I was young, you know, it was coming every other year, and most of the children before the time of vaccination, they will get measles. And of course there was complication, as I remember, and some got encephalitis. The current rate of measles is 1 case per 1 million population. Okay. Then the transmission of measles is through the respiratory tract or conjunctiva, and mainly droplet infection. Patients are infectious. This is very important to know that the patient is infectious from 3 days before the appearance of rash up to 4 to 6 days after its onset. And this is the time, you know, of isolation. It's important for this one for time of isolation. That's why we have some medical students who got measles, and we ask them to stay at home and to be isolated for 6 days after the appearance of rash. 90% of the exposed develop measles, so it is highly infectious disease. And in some saying, they told that it can cause infection even 30 meters wide or 30 meter vertical. So it is very infectious disease. Viable virus may be suspended in air up to 1 hour after a source case leaves the room. So no need even to do fumigation for the room after the discharge of the patient. Just you say 1 hour, the virus will not appear after 1 hour, and you can admit another case after that. Regarding the pathology of measles, there will be necrosis of the respiratory tract epithelium, lymphocyte infiltrate, and there is vasculitis in small blood vessels on the skin and on the oral mucous membranes, as we will see in the clinical picture. The histology of measles infection, there will be intracellular edema and formation of epithelial syncytial giant cells with up to 26 nuclei. Viral particles will be available in the giant, including in the giant cells, and there will be lymphoid hyperplasia, and maybe this is the cause of getting appendicitis sometimes during measles, because of hyperplasia causing obstruction of the lumen. There is Warthin-Finkeldy giant cell, which this cell, if it is available or if we detect it, so it is pathognomonic. So you can swear that there is measles. If you see these cells of measles, they are up to 100 nuclei and intracytoplasmic and intranuclear inclusions. So Warthin, Finkeldi giant cells are pathognomonic for measles. The measles has 4 phases: the incubation period, the prodromal illness, the exanthematous phase, and the recovery phase. During incubation, the virus migrates to regional lymph nodes. There will be primary viremia, virus spread to the reticuloendothelial system, and a secondary viremia characterized by spread of the virus to the body surfaces causing the rash. During the prodromal illness, it begins following the secondary viremia, and it is associated with epithelial necrosis and giant cell formation in the body tissues. While the exanthematous phase, there is an onset of rash. So now we will start the clinical manifestations of measles. First of all, the incubation period of measles is about 10 days, and that is between 8 and 12 days. And if you go to the WHO report, you will find that most of the cases had in the outbreak had incubation period from 10 to 12 days. There will be high fever, enanthem, and you know there will be exanthem later on. We have to differentiate and to look thoroughly whether it is enanthem or exanthem if you have any questions. So regarding enanthem, it is a lesion in the mucous membrane, while exanthem, it is the rash, lesion in the skin. You have to differentiate between them. And we have 3 C's: cough, coryza, and conjunctivitis. All of these things are, in the prodromal stage. Then the complex spot, which is enanthem in the mucous membrane, will appear. And this complex spots, these complex spots are pathognomonic for measles. So if you will find the complex spots, you will swear that this is measles, and you isolate the patient and you tell them just you wait 1 to 4 days for the appearance of rash. What is complex spots? There is a red lesion, which is congestion of the mucous membrane, with a bluish white spots in the center on the inner aspect of the cheeks at the level of the premolars. So with the tongue depressor, just you look to the cheeks from inside, and opposite the premolars, you will find that it is very congested and there is a bluish white spots. These are the complex spots, which is pathognomonic for measles. The complex spots may spread to involve the lips, the hard palate, and the gingiva. It occurs in the majority of cases. This is very important, the complex spots, for the diagnosis. The symptoms of the disease, they will start for 2 to 4 days, and after the 4 days, and after appearance of rash, the symptoms will be minimal. So there will be very high fever. Once the rash will appear, the fever will drop. So the rash begins also around the forehead first, around the hairlines, then behind the ears, and on the upper neck as red maculopapular rash. After that, there is spread downward to extremities, reaching the palms and soles in up to 50% of cases. This is important if you will find the rash in the palms and soles, and this will be one of the differential diagnoses of the palms and soles rash. Between them is hand, mouth, and foot disease and the rickettsial diseases. The clinical manifestations to continue with the onset of rash, symptoms begin to subside, rash fades over about 6 to 7 days in the same progression. It will start from the face, then start to fade from the face, then go to fade from the trunk and extremities. And it will leave fine desquamation. Fine desquamation is important because in the rubella usually will not leave fine desquamation, but in measles and in scarlet fever, the rash will, when it will fade away, it will leave fine desquamation in the skin. Usually in measles, there is a dry cough, very irritative cough, and usually it lasts for long time. Often after relief of the rash, and it will take about 10 days, and some cases may be more than that. One of the clinical manifestations is generalized lymphadenopathy with cervical and occipital lymph nodes. This, as you see this picture showing the eyes are red, conjunctivitis, we told the 3 C's, coryza in the nose, conjunctivitis in the eye, and cough, dry and irritative cough in the chest. This picture is very clear about complex spots, congested cheek from inside, mucous membranes, and you will find, the white spots opposite the premolar teeth. Here the body, measles rash, we told more than 40%, we have rash in the palms and soles. There is what is called inapparent measles infection, either subclinical infection or atypical measles. The subclinical infection is mild. In individuals who are receiving the passive antibodies or receive the vaccine, there will be few rash, mild disease, a few symptoms, but it is not infectious, not to transmit infection to household contact. While the atypical measles is a severe disease at the same time of receiving original formalin inactivated measles vaccines. Now I think this vaccine is no more available, and it is replaced with a vaccine with less complications. In atypical measles, there will be high fever, headache, followed by maculopapular rash in the extremities, and become petechial and hemorrhagic, purpuric, and progress in a centripetal direction. So it will progress going to the center of the body, frequently complicated by pneumonia and pleural effusion. So the atypical measles, it is a severe measles, while the subclinical infection is mild measles. How to diagnose measles? Usually diagnosis is clinically according to the clinical picture. First of all, from the history of contact or case of measles, for example, history of vaccination history against measles, and whether the patient receiving booster or not. Then regarding the fever, regarding the signs of coryza, cough, and conjunctivitis, regarding the complex spots which are, pathognomonic for measles. Then regarding laboratory investigations, there will be decrease in the total white blood cells and lymphocytes. To diagnose, diagnosis will be appearance of IgM antibodies, which appears 1 to 2 days after the onset of rash and remain for 1 month to any time during or shortly after the disease. If you will make an IgM antibody, you will, if one find it positive, so you can diagnose measles in this period. Or to have fourfold rise in immunoglobulin G, and this is most of the viral diseases you can apply this point. Viral isolation from the blood, urine, or respiratory secretion, and PCR usually now is the most reliable diagnostic measure. Differential diagnosis of measles, all the diseases we mentioned earlier about infectious diseases with rash, including rubella, adenovirus, enteroviruses, Epstein-Barr virus, that's infectious mononucleosis, exanthem, subetum in infants, erythema infectiosum in older children, or especially school children, mycoplasma pneumoniae, group A streptococcus, Kawasaki disease, and drug eruption. What are the complications of measles? First of all, morbidity and mortality from measles are greatest in patients below 5 years of age, especially those below 1 year of age, and those more than 20 years. This means the extremes of the age of measles. Usually, measles infect the children, we told. Childhood disease. So, extremes below 1 year, the measles will be severe, and after the age of 20 years, as happened in the outbreak in Gaza. What are the risk factors for the severity of measles? Crowding, severe malnutrition, low serum retinol. Measles lower serum retinol or vitamin A if it is low, and really in one of the researches here in Gaza, they found that about 60% of the population have some degree of vitamin A deficiency. So take care for the viral infectious diseases, especially measles, to take vitamin A. The immunocompromise is a very, very important risk factor because usually the measles is very severe and can cause pneumonia or encephalitis. Again, malignancy, pneumonitis in malignancy occur in 58% of cases, and encephalitis in about 20% of the cases. Complications of measles, pneumonia. Pneumonia is considered a leading cause of death. As we mentioned, pneumonia and encephalitis. Pneumonia, the most common cause of death. There will be giant cell pneumonia or secondary bacterial infection after pneumonia with Streptococcus pneumoniae, Haemophilus influenza, or Staph aureus also can cause to death. And again, bronchiolitis obliterans. Other complications like a croup tracheitis or bronchiolitis, it may require intubation, especially the tracheitis or the bacteria tracheitis. Mostly it is caused by staph and will produce very thick secretion there. That's why it will block the respiratory passages. So this patient will need intubation and ventilatory support, lavage, until the infection will be resolved. Again, the acute otitis media is the most common complication of measles. Sinusitis, mastocytitis. As you will see, there will be direct spread from the throat or mucous membranes to the surrounding. Like otitis media, sinusitis, croup, and all these things, then it will descend to pneumonia and so on. We told about viral and bacterial tracheitis and how we manage suppression of PPD skin test. There is some relation between measles and tuberculosis. So the protein purified derivative or tuberculin test of tuberculosis, it will be suppressed when the patient has measles. So don't check tuberculosis except after the measles will be cured. Again, another relation with the tuberculosis, this measles will cause activation of pulmonary tuberculosis and even cavitation. Another side effect like diarrhea, vomiting, dehydration, and again appendicitis, as we mentioned, because of obstruction of the lumen by the lymphoid hyperplasia. More complications like the febrile convulsions when the fever is very high. Encephalitis is the most important after the pneumonia. Encephalitis can occur 1 to 3,000, yani one case in 1,000. The rate of infection of encephalitis, and this is very important, and usually we differentiate it from the panencephalitis, which is 1 to 100,000. So encephalitis will be 1 in 1,000 cases, mainly in adolescents and adults. Begin by during the exanthem, this means during the rash, and presents this encephalitis with convulsions, lethargy, coma, and irritability. The CSF shows lymphocytic pleocytosis in 85%, like the viral meningitis, and elevated protein concentration. 15% of patients die, and 20 to 40 patients will live, but with sequelae, including mental retardation, motor disabilities, and deafness. So encephalitis, the second cause of death from measles, and it is severe and usually 1 in 1,000. Another complication is subacute measles encephalitis, and it will be 1 to 10 months following measles in immunocompromised patient. There is again hemorrhagic or black measles. This is fatal, and again keratitis, one of the complications, and thrombocytopenia also can occur following measles. There is here important note: when measles occur to pregnant mothers, there will be high maternal mortality, will be abortion or stillbirth, and there will be congenital anomalies in 3% of live-born infant. Now, the most important complication of measles, which will not appear in the time it will appear later on, after 7 to 10 years of measles, which is subacute sclerosing panencephalitis, SSPE. It is a chronic complication of measles, delayed onset usually, we told 7 to 10 years, and usually fatal disease. It is considered persistent infection with measles. The virus will be dormant intracellularly in the CNS for several years, and after 7 to 10 years, it regains virulence and attacks the cells in the CNS and destroys the cells of the CNS. So it is considered a slow viral infection, result in inflammation and cell death, leading to neurodegenerative process. The incidence 1 to 10 to 100,000. We told encephalitis 1 to 1,000. The SPE is 1 to 100,000. The age of onset, and those who got measles below the age of 2 years, 50% of panencephalitis can occur in 50% of the cases will be in the children below 2 years, and 75% of the cases will be below the age of 4 years. Males are affected twice as often as females. How to diagnose subacute sclerosing panencephalitis? You will find measles antibody in the CSF. There is characteristic EEG, and CSF analysis reveals normal cells but elevated immunoglobulin G and immunoglobulin M antibody titer in dilution 1 to more than 1 to 8. There was before diagnosis from the brain biopsy, but now no longer used for the diagnosis. The management of subacute sclerosing panencephalitis, we told it is a fatal disease. That's why the management is only supportive. And most die within 1 to 3 years of onset of infection or loss because of infection or loss of autonomic control mechanisms. What are the lines of treatment of measles? First of all, management of the symptoms, supportive measures like antiviral, for example, antipyretic. But antiviral therapy is not indicated and not effective in measles. We have to maintain hydration and oxygenation because the patient may have gastroenteritis and dehydration. So we maintain hydration and oxygenation. We give antipyretic for fever. We give respiratory failure in cases of croup or pneumonia. Measles infection in immunocompromised patient is lethal, as we mentioned before. Ribavirin was active in vitro against measles virus, but not approved as a treatment. One of the most important treatment is the vitamin A. The vitamin A, we told that the retinol will be reduced by measles, and if the patient himself already has vitamin A deficiency, so the symptoms will be severe and more morbidity and may lead to mortality as well. So vitamin A deficiency in children associated with increased mortality from a variety of infectious diseases, including measles. And not only measles, many of the infectious diseases will be more severe with vitamin A deficiency, especially viral diseases like influenza, coronaviruses, and others. 22 to 72% of children with measles has low retinol, and vitamin A therapy reduce morbidity and mortality. This is the regime we give usually after the age of 1 year 200,000 international units orally, while those 6 months to 1 year we give 100,000 international units. This is all of the thing, but we can repeat the dose the next day and again 4 weeks after in children with ophthalmologic evidence of vitamin A deficiency. As we mentioned before, ophthalmologic evidence like for example, dryness, keratomalacia, keratoconus, vitodispots, and so on. What is the prognosis of measles? The death to case ratio fell to 1 per 1,000 cases. Pneumonia and encephalitis are the main leading causes of death, and immunodeficiency condition is 14 to 60% of deaths. How to prevent measles? First of all, isolation is the most important. Because patient shed measles virus within 7 days after exposure to 4 to 6 days after the onset of rash. So during this period, the patient will be isolated and from contact. In hospitals, usually airborne precautions should be taken place. In immunocompromised patient, the virus usually shedding will be for more long period. That's why all during period the isolation will be longer until complete cure from measles. One of the important, cost-effective preventive measure of measles is the vaccination. As we mentioned, MMR vaccine, which is given at the age of 12 months and 18 months. There is post-exposure prophylaxis, which is very important. The vaccine itself can be given early in the incubation period. And in some patients, we can give the immunoglobulin. The vaccine is effective in prevention or modification of measles if given within 3 days or 72 hours. 72 hours of exposure. Immunoglobulin may be given up to 6 days following exposure to prevent or modify the infection. And as much as possible, you give it earlier during the incubation period, or earlier the better during the disease. Immunoglobulin is indicated for susceptible household contact of measles, especially infants below 6 months of age, as we mentioned, because this risk factor, pregnant women, and immunocompromised patients. These are the references for my lecture, including also the WHO website. So now, regarding the questions, you can ask the questions anytime during, in the email or through the messenger. And again, later on, we may register some videos and make live sessions in the Zoom program, to receive your questions, and we answer all your questions. Now, by the end of this lecture, every student knows about infectious diseases with rash. He will know the description of rash. He knows about measles, epidemiology, pathogenesis, clinical picture, diagnosis, complication, managements, and prevention. Thank you very much, and see you in another lecture.